right, awesome. All right, so thank y'all again for being on today's Zoom. We are going to focus on some chapter 15 CPT coding because that is what in the assignments and on the exams and stuff, and also from verbal feedback from you guys. CPT and ICD-10 are confusing, and we have a lot of people, we have new people that start in our course every week. And then after these folks start, it's a week before they even have their CPT manual. So some of the assignments and stuff that you guys are doing and you've got your manuals there, other people don't have them. And even some of y'all that do have your manuals are not that familiar with them. So we're going to see if we can't clarify some things today as it pertains to chapter 15 coding. Okay. And then on Monday evening, we are going to have a CPT workshop. And it's just going to be an informal Zoom. And we're going to talk about it's just going to be basic familiarization with the CPT manual, sections, labeling, stuff like that. And then I think the following Monday night, we're going to do one on ICD-10. So if that is something that you guys are struggling with, or you just want some tips or tricks, whatever, come to that. It's not an assignment. I'll probably give extra credit to anybody who shows up just because, but it's not graded. It's not mandatory by any means. It's just something that I'm doing just to try to help you out. And I am going to record it and post it to the website too. So if you can't make it, you're with your family at that time or at work, whatever, don't worry about it. Okay. But that is something that you guys have expressed interest in knowing more about. And it's something that you're going to use a lot. So we're going to see if we can't help to make it all click. Okay. All right. So what I want to do today is go through some practical questions where we find the CPT code. And this is in your chapter, in the realm of chapter 15, dealing with the musculoskeletal system. Gotta love medical terminology. But I've got a little presentation, so I'm going to share my screen and we're going to go through and just basically walk through it together, how we find these CPT codes for some of this stuff. All right, give me one sec. Really? And of course, nothing's in the way. Okay, excuse me one quick second, y'all. I have got to sneeze. Ugh, sorry about that. That's leftovers from being sick. My sinuses have been going crazy. But okay, can everybody see my screen? Chapter 15, musculoskeletal CPT coding.
Yes, ma'am.
All right, good deal. Okay, so one of the first things I want to talk about, I don't know if you guys have noticed this or not. Some of you may have caught on, but the way the CPT manual is set up, our chapters are basically walking through it section by section. We started out with E&Ms and then we moved on to anesthesia, and now we did surgery and now we're in musculoskeletal, and if I just switch to the next section, which is respiratory system, I know that's going to be chapter 16. We're going to cover the coding in the respiratory system. All right. And so on and so forth until we go through this entire manual. So when we're looking at chapter 15 and it's musculoskeletal, we're looking at just that section, okay? All the codes that we're looking in for chapter 15 are going to be found in between. All right, so pages 131 is where it starts, and it's marked, I don't know if you guys can see too good, but it's orange, the label on the end, and it goes to page 216. So 131 to 216. So, it's not even 100 pages, this entire section. But any of the codes that they're looking for you to find are going to be found in these pages. Okay. So that'll kind of help like if you're trying to figure out what keywords you're looking for, if you end up in another section, you went wrong somewhere and you might need to look at it again. Okay. All right. So again, page 131 is going to be the beginning of this section. It's where your table of contents is going to start and your anatomical illustrations. And actually, this one that I have here on the screen is the one that is on page 131. And there were several of the questions when going through some of your practice problems that I looked at that I had to revert to this drawing to figure out what part of the body I was supposed to be looking for. Because I don't have a medical degree. I'm not a doctor. All of my medical stuff comes from coding and billing experience, all of my medical experience, and from my own health issues, and those of my family. But that's where all my experience comes from and knowledge. So you guys will pull from your own experiences, and then at work you'll learn all that too. All right. But these anatomical illustrations are really, really helpful in trying to figure out what section of the body you might need to be looking at, what codes might need to be added in that have to do with those certain sections of whatever part of the body that you're looking at. So you want to look at those illustrations, especially if you see words in the content that you have no idea what it is. Scan over some of those illustrations and more than likely you'll catch that word or something just like it, and it'll help you narrow things down. Okay, so those are super, super helpful, and all of the sections have these illustrations of that part of the body labeled and just full of good information. All right, so let's go ahead and look at our first one. And our first one is almost the worst one. I think we're going to get the worst one out the way first. Okay, so Julie Mason, age 5, is coming in today to have her long arm cast replaced with a short arm cast. She sustained a torus fracture of the upper end of the radius and is 1 week post-op. All right, so we're going to code on the information that we have. And what we want to do is figure out what CPT code we need to put down for this, right? All right, so where do you guys think we're going to start with this?
Fracture.
Yep, we can start with fracture. How else could we start? Because there's more than one way. You can do it. There's more than one way to skin a cat. Okay, so you can start
and cast.
Yes, exactly. You can start with cast. You can start with fracture. If you know what and where the radius is, you could probably start with that as well. But for the purposes of today, I didn't know what exactly a torus fracture was. I knew where the radius was, but I didn't know what a torus fracture was. So I started with cast on this one, the easiest thing, right? All right, so we're going to start with cast. So the first thing you do, your alphabetic index and your CPT is located in the back. Okay, it's the last thing in there is your alphabetic index. You go to that index and you find cast. And if y'all want to follow along, you can. And if you don't want to, I'll just talk about it. But just it helps if you do follow along. All right, so when I go to cast in the index, which is on page 1060, okay, under cast, it starts listing your parts of the body. Below the knee, club foot, cylinder, elbow to finger, finger, halo, hand and lower forearm, long arm, and it goes on and on, shoulder, leg, etc., etc., right? So we know with this, we're looking for, she's got a short arm cast is what they're doing today for a torus fracture, upper end of the radius. If you don't know what the radius is, you can go back and look at that lovely little skeleton picture that is nice and labeled, but it is a part of the forearm here, just to save some time. All right, so that is going to be a short arm cast is going to be this part. The radius is this upper forearm part. So that is within the elbow to finger range. So that's where I would go next. I would go to that elbow to finger, which is code 29075. Okay. So I know that's going to be in the musculoskeletal section. So you're going to go back and into your orange section and find code 29. What was that? 29075. Okay. All right. So that, if y'all are following along, is going to be on page 211. All right. In the left-hand column, about halfway down, 29075, elbow to finger, short arm. So that fits. Now there's not too many subsections there, or really any subsections on this one. Your other codes around it, because you always want to look, especially if it gives you a range. Sometimes it'll give you one specific code. Sometimes it'll give you a range of codes. Go through that range and make sure that the one that you're picking is the most specific to this problem. Okay. And pretty much 29075 covers this. Elbow to finger, short arm cast. Right. So our CPT is going to go ahead and it is going to be the 29075. All right. Is there anything that we need to add on to that? Do we need to use a modifier here? Anybody? Yes, no, maybe so.
I'm sorry, I missed it. What happened?
Do we need a modifier? Our CPT code is going to be the 29075, right?
CPT code?
It's 29075. We found that on page 211. So now we've got our CPT code. Are there any modifiers that would apply to this?
So 11.
I don't think a modifier will
I
be
don't
added
think
to
so.
because they're saying she's having a short arm cast put on because they're taking off the long arm cast, but it doesn't say any additional things added to it.
Yeah, I want to say the code was pretty specific on what's going on in the scenario. Is like spot on. So I don't think it needed modified. I could be wrong though.
It would be 50.
Close. It does take a modifier, and I'll tell y'all
Oh,
why.
okay.
It gives us one little clue, this last sentence, and is 1 week post-op.
Oh.
What does that mean? She means she's in that post-operative period of probably for a fracture at least 30 days. This is 1 week after surgery, so this is definitely going to be post-op. So yeah, we're going to need a modifier that lets the third party payer know that this is, this is included basically in that global period, that global surgical period, right? So which modifier? This is going to be additional procedure during post-operative period, probably by the same physician. Which modifier is that going to be? Well, where do we find our modifiers in CPT manual? Anybody know?
The index.
For
Appendix
the
A.
modifiers is at the beginning of the,
It's at the front of the book.
yep.
Appendix A.
I don't know what page.
CPT manual. It's actually in the back. It's right before your
In the
alphabetical
back?
index. Page 917.
Yes, the appendix A.
Right. Appendix A. All right. So that's where all you can find all those modifiers and exactly what they mean. I want y'all to look at modifier number 58.
Miss Brandy, I'm gonna have to turn my video off. Okay, I'm still here though.
Yeah, do your thing.
Okay.
Stage.
Modifier 58.
Mhm.
Professional, qualified healthcare professional. Girl. Okay. Modifier 58.
Yes, ma'am.
To necessarily indicate that the performance of procedure of service or procedure period was planned and anticipated stage. Okay, I have it.
Right. So does that make sense? Staged or related procedure or service by the same physician or other qualified health care professional in that practice, okay, during the post-operative period. And what that means, staged or related procedure, when they fixed this fracture, they had to stabilize it with a cast, right? They knew her original cast when they fixed it was a long arm cast. They knew that they were going to come back a week or so later and take that cast off and replace it with a shorter one.
Okay, yeah.
Okay, so that's what they call a staged, something they knew was coming up, right? They knew they were going to have to do this. So that's why it qualifies as the staged or related procedure.
Because it was still in that global period.
Correct. Still in that post-op period.
Mhm.
Yeah. So you would add the 58 on there.
Okay.
Yeah. And I'll tell y'all this too. I don't think any other of the ones that we use today as examples in this presentation require a modifier because they don't have, like, this was the longest one. The rest of them are kind of short and simple and to the point. But I just wanted y'all to see, especially when you have a longer scenario, check out all your information. Check out all the who, what, when, where, and whys. Okay? Your who, what, when, where, and why. And a lot of the time, those will let you know if there's a modifier needed or not. All right. So does that make sense to everybody? We looked up cast. We got to the 29075. We had to add our modifier 58 on there. Okay. All right, let's move on to number 2. Percutaneous skeletal fixation of closed calcaneal fracture requiring manipulation. When I looked at this the first time, I didn't know what calcaneal was. I'm still not 100% sure of exactly what it is. I'm guessing it's that bone in your heel. And if you look at this little picture right there, which is on page, that's one of those lovely illustrations at the beginning of the section.
135.
135, there you go. But you can see calcaneus. See, I even said that wrong. Calcaneus is this bone at the edge of the heel. So we know now at least we're dealing with the foot, because before that I didn't even know what part of the body I was supposed to be looking at. Okay. All right. So where do y'all think we're going to start with this? What are we going to go search for in the index?
Fracture.
Yeah, you could do fracture. What else could you do?
How about the manipulation?
You can do manipulation too. Yep. You could do fracture. You could start with manipulation. Generally, I start with whatever it is in there that I don't know. Because usually that's the medical piece that I don't know. So I started with calcaneal. Okay.
I thought of that too.
But I mean, y'all, either which way you go, you're going to end up in the same place. Okay. Because whether you look it up, once you look it up by manipulation, it's going to give you a list of body parts that's able to be manipulated and what page or what code corresponds, right? You look up fracture, it's going to give you a list of body parts that can be fractured, right? Same thing with calcaneal. I had no idea what that was, but I just went ahead and looked it up, and I found that calcaneus, I think was how you say that, and what it was. And then from there, I got to, let's see. All right, page 209. Let's see. Do y'all have, go ahead and look it up. One of y'all use fracture. Whoever said fracture, look it up by fracture. The other one, look it up by manipulation. And let's see where it gets us. Let's
Okay.
compare.
Well, for fracture with bone graft is 28420. With manipulation is 28405 to 28406.
Very good. Very good. So we're going to look at that
And I found those
28405 and 06, right?
under calikinesis.
Mm-hmm.
Yeah, calikinesis.
Yep. And we come up with that 28405 and 28406. That's a range. So now we got to go in there and figure out which one. Excuse me. Which code it's going to be. I hate coughing and sneezing at y'all. Excuse me. All right, so let's look at page.
Because if you
209.
use 28406, it says percutaneous skeletal fixation of calcaneal fracture with manipulation.
Which one is that?
28406.
So that fits, right?
Yes, ma'am.
All right, so there we go. There we go. And let's see. Yep, that's almost exact wording.
Yes, ma'am.
So that's about as specific as we can get, right? And there's no subsections or anything like that. So there we go. 28406. Very good. But you see how you can get to it from different ways. Just because one word stands out to you, a different word may stand out to somebody else. It doesn't make either of them wrong. Okay.
And it's gonna still bring you to that one code.
Yep.
If you try to fracture in, okay.
Yep. It still brought you to the same place. Because when I looked up calcaneal, it brought me to, it gave me, I looked at calcaneal, and then under that, it was, I think, fracture, and a bunch of different procedures that could go along with that. Okay. And I just picked out the one that fit my scenario.
Okay.
And got to the same place. All right. Come on. All right. Number 3. Closed treatment of a single closed metacarpophalangeal dislocation.
You said it right.
Distal end with manipulation and without anesthesia. No, thank you. Number 1, no, thank you. I'll pass on that. Hard pass. All right. All right. So, y'all know me. Like I said, I always start with the biggest, longest word I don't know. So that would have been metacarpophalangeal. And the only thing I recognized out of that was phalangeal, because I know that fingers are phalanges. I picked that up from Grey's Anatomy. I'm a Grey's Anatomy fan, and I know that fingers are phalanges. So that was the only thing I knew out of there. So I went with that. Look that up in the alphabetic index. Let's see. You could also do it with manipulation. Yeah, either which way. I don't know if distal would have, I don't think distal end would have got you there. You could have gone dislocation and then found the body part under there. But I think your quickest way would have been the metacarpophalangeal. Okay. All right.
That's
So
how I found it just now.
what's it telling you?
Close treatment. Distilled anesthesia. No. It says, I don't want to get the wrong code. Hold up.
No, let's do it. If it's wrong, we'll figure out why, and we won't make that mistake next time.
Okay, so once I find the metacarpophalangeal.
Uh-huh.
Oh no, that's not the right one. I'm sorry. Oops.
You're okay.
Hold on.
Let's see.
Okay, I found the right one. It was on the next page. All right. And we are looking for arthritis and diagnostic surgical. Manipulation. Close treatment. Dislocated.
Wouldn't it be 26,340?
340? Nope. Nope. Okay. If you've got metacarpophalangeal joint, under that, it starts with arthrodesis.
Yeah.
And then the next column continues with biopsy. And then capsule. And then a couple of options down, you have dislocation. Okay. And that's what we're looking at, the dislocation of the metacarpophalangeal joint.
Closing open treatment. Okay, so it's gonna be 26,715.
Nope.
But then it says it's supposed to be
closed
closed treatment, and it said with manipulation.
Oh, 26,740.
Let's look at.
But then when you go to 26,340, then it says manipulation joint under anesthesia, but it says and without anesthesia. So you're really looking for without anesthesia.
Right. So let's look at, let's see, the first, under dislocation, our first option that fits. Let's look at closed treatment and see what that says. Okay. That 26700 and 26705. Okay. But yeah, 26340 would have been the first thing I looked at. But again, it didn't fit our scenario, so we got to rule that out.
So it's the 26700 is without anesthesia.
Bing, bing, bing. Very good.
Then this procedure right here wouldn't be too bad. When you say no, because they say without anesthesia, it's not too bad. It's just pulling the bone back into the joint.
Back in place.
Yeah. It's not too bad.
Still, I feel like that would hurt. But I have arthritis.
I guess you have to have good pain tolerance.
And yeah, I ain't got that neither. But yeah, that 26700 is going to be the one that fits the best.
Okay.
All right. All right, number 4. Depressed frontal sinus fracture repaired using open treatment. What y'all gonna look under in the index?
You can look under fracture, but then also you could look for sinus.
Correct. Correct. All right. So y'all look, tell me what you come up with. Y'all found anything?
Still looking.
Okay. All right. So I think when I did it, I did go through sinus
Yeah.
and then found fracture under that.
But don't it take you all the way back to nasal?
Mm, let me check back. I don't think so though. All right. So if you go to sinus, nothing under sinus really jumps out at me as fitting
Mhm.
a fracture. So I'm thinking
I did see it say see nasal
nasal
sinus.
sinus. Did you look at nasal sinus and see what that says?
Yes, then it come up with fracture, then they have open treatment.
There you go.
The code was 21343 and 21344.
21343 and 21344. All right. So let's narrow it down. Which one's it going to be?
Okay.
Which one of those codes fits best and why?
It will be 21343 because it says open treatment of a depressed frontal sinus fracture. Because if you use 21344, it would be open treatment of a complicated frontal sinus fracture.
That is correct.
And you just asking for the depressed frontal sinus fracture.
Exactly. Exactly. That one fits us the best. It's not giving us anything about a coronal or multiple approaches or anything like that. It's just a depressed frontal sinus fracture that was repaired via open treatment. So yeah, the 21343 is going to be the code we use. But do you guys see how you can start out with one word, like I went sinus, and fracture wasn't necessarily under there, and we went to nasal sinus and looked that up. Do y'all see how they fit together, how they link together, how we got to where we got?
Yes, ma'am.
What about our other folks, y'all? Y'all hanging in there with us too?
Yeah, it was 213 what?
343.
3, 4, 3. Okay. Oh, I'm ripping pages, Lord. Over treatment of depressed frontal sinus fracture.
Yep,
Well,
that's the one.
yeah.
And it doesn't give us any other information for modifiers or anything else.
Right.
So that's what we would run with. All right. Very good. Number 5. Aspiration and injection of a bone cyst. That sounds uncomfortable. All right, where are we going to start on this one, y'all?
Injection.
You can.
Sis?
Sis.
You can. All good options. All right, one of y'all look up cyst. One of y'all look up injection. Somebody else look up aspiration. You can go 3 different ways.
Okay, I have aspiration.
Okay.
Of bone is 206.15.
All right. Let's see. That's going to be on page 143. The 20615. And let's see how that fits. Pretty accurate, huh?
Right.
Pretty dead on.
You said 100 and what?
43.
Okay. And we have aspiration of injection of treatment of bone cysts. Dead on.
Dead on the money.
Injection of bone submitted material for bone marrow lesions use 0707T.
Right. And we don't have any information regarding bone substitute material or anything else. So that's not going to apply to us today.
Okay.
So that 20615 is going to be your code. All right. Now, any of y'all that went injection or bone cyst? Did y'all end up y'all got to the same place?
Yes, I did the cyst with the bone cyst, and it still brought me to 20615.
Awesome. Awesome.
Because it said injection.
Absolutely. Awesome. All right. Last one we're going to go over. Okay. Replantation of index finger, including sublimis tendon insertion, following a complete traumatic amputation. Code only replantation service. So all right. So what that tells me right off the bat, this last sentence, code only replantation service, that tells me that I'm not going to have to worry about this complete traumatic amputation. Not going to have to worry about that. That shouldn't come into play really. All we're worried about is the replantation of the index finger, including sublimis tendon insertion. I am guessing that because they gave us that information, including that tendon insertion, that's going to play a part in our code. That's going to play a part in differentiating which code we're going to be using. Okay.
Mm-hmm.
So I have 2824 through 2827.
That sounds right. How did you get there? What keywords did you look up?
Replantation.
That's the way I went to. Yeah.
And it has
What you say the code was? What you came up with, Martinique?
yeah, that's right. 2824 through 2827.
Okay, well, I came up with 2816 to 2822 because they say a digit. An index finger is a digit because a thumb is different from the index finger.
From the digits, right? You're right.
Mhm.
You're right.
Because my son had the thumb amputation thing and they had to put it back on, but the index finger is considered a digit and the thumb is. A lot of people didn't know that the thumb is not considered a
A
digit.
digit. That's correct.
Mhm.
Most people don't know unless you've had something go wrong with
Mhm.
your hands like that, or done coding for this kind of stuff. Most people do not know that a thumb is not considered a digit.
And
Yeah,
what you
I didn't know it either till I was in nursing school, so I found that out. And then when I had surgery on my wrist and in my thumb area, then I found it out from my doctor.
and what was your code again, Zakayla?
I came out with 20816 through 20822.
But you see how the code ranges that you got and the code ranges that she got overlap?
Right.
Yes. Yeah, they kind of still, it's like mine's coding came first and then after the 20822, then it jumps to 20824. It's like right after when you do the thumb.
Oh yeah, it's right above.
Yeah.
Okay.
So which one are we going to use? Which y'all think we're going to use?
208. Wait. Femur, hand. 20808.
Uh-uh.
No.
Look
It's
within that range.
is 20816 replantation of a digit excluding the thumb.
Right? But
20802.
it's going to be the 20822. And
Yeah,
the reason
replantation
being,
of the digit excluding the thumb. Complete amputation.
but
Yeah,
look
because
at
it
that.
saves somebody.
Look in parentheses in that 20822 explanation. Includes distal tip to sublimus tendon.
Yes.
Okay. And that's what was in our scenario, including sublimus tendon insertion. So that's why it's going to be the 20822 versus the 20816 because of that tendon. Okay.
Yeah.
All right. All right. But you see how even though y'all went two different ways and you ended up with two different code ranges, the code that was correct was included in both of those ranges, right?
Right.
Exactly. So it's all about just narrowing it down, whether that be by body part, whether that be by procedure, however you need to do it, whatever way works for you, you know. If it's a lot easier for me to understand fracture than it is metacarpophalangeal, right? But people who have more experience with medical terminology may find it easier and faster to go that route. And again, there's no wrong way. You're going to end up in the same place. So don't let not being that familiar with the medical terminology overwhelm you or get you down. It's not, like I said, as long as you are familiar with the manual and you know how to use the manual, where to go to get the information that you need, you know, and ICD-10 is the same way, y'all. You're going to start out in that alphabetical index. You're going to find those keywords, start out in that alphabetical index, and go from there. Okay. And then it's a process of elimination from there to get to that right code, that most specific code. All right. So that is it for my little practices. Did that help y'all at all? Did walking through it with me help at all?
Yes, it did. I'm just waiting to do that ICD-10.
That ICD-10 ain't no joke.
That's the
No,
one I'll be getting confused on a lot.
Man.
but y'all, I'm telling you, it's very similar. If y'all got the basis of the CPT, you've also got the basis of ICD-10.
Yeah, because it go the same way. It's just
it's set up differently.
is woo.
It's set up differently, and you got to think about it like this too. With CPT, you're dealing with procedures and services. With diagnosis, it's more diseases and injuries, right? Things you have, things that are done to you. It's, one of them is going to be what's done to you, and the other one is going to be the why it's done to you, the diagnosis to why this service was done or procedure was done. Okay. And yeah, in ICD-10, that stinking alphabetic index is in the front. CPT, it's in the back. So they're set up differently, but a lot of the same information, y'all, to get to where you need to get. And the same thing with diagnosis. Sometimes you can find, like I say, there's multiple ways to skin a cat. Okay. So just keep that in mind. Don't let it overwhelm you. The longer you do it, the more you do it, the more you use this book. Every time you break that sucker open, it's going to click a little bit more. I promise. And as we go along, eventually, by the time y'all are done with this, it's going to be like, you want me to find a CPT code? Fine. Fine. If I must for the grade, fine. So
I'll be learning a lot of good stuff. I'm sitting here laughing when I'm doing the homework, and some codes I'll be thinking, I say, when you go to the doctor and the doctor be saying, well, I don't know if I want to do this procedure. And you thinking to yourself, if I give you this certain code, you could use this code and you'll get paid more. You don't want to do that procedure on me then. That's what I'll be joking. I'll be saying, I'm gonna have to tell my doctor about some of these codes he could use. Because a lot of them be trying to say, I don't know if I want to do that. And I'll be needing it done. I say, if I tell you about certain codes, you may
let
could
me tell
use
you a
those.
secret though.
Because some
that
folks
doctor-
done to me. Like,
If that doctor doesn't do his
so
own
that's what
coding
they
and
was
billing,
doing.
he probably don't know what he's getting paid for what.
That's true.
Unless he's like a surgeon. A surgeon can tell you pretty much what they charge for said procedure. But your average general practitioner, ENT, something like that, exactly what they gonna bill for what procedure, they ain't got a clue.
Just like when I learned in anesthesia, I didn't know anesthesiologist makes a little bit more than a physician does.
Yeah.
And I was like, okay, that's why they do their own codes. And I say, so when they're standing up in there with the physician, then they could say, hey, you have to listen to me. I make more than you.
Well, I mean, depending on what they're doing, yeah. Depending on what they're doing. Like I said, that's why anesthesia is its own thing. Because it's so specialized, and they've got to know those medications, the different gases, injections, and all that stuff. And you got to think about it. If they don't know their stuff, they're gonna kill somebody quick. So, so yeah, they make some money. Call them
So
the
you
gas
be
man.
wondering about them codes to be telling your doctor. Some of your doctors, you have to let them know about certain codes if you want to have a certain surgery done. And a lot of them be, and so they end up telling the nurse, and she be like, well, you have to put that code in. That's the only way certain insurance is gonna pay. Because they might put in a code that the insurance keep knocking it back and they want trying to understand why until you really know which code you have to put in for them to pay for.
That's exactly right. That's exactly right. And there are some physicians, if they know, like certain people that deal with a lot of elderly patients, deal with Medicare a lot. Medicare is your big one about not covering certain things and
Mhm.
stuff like that. And that they figure out quick what they can do for these patients that Medicare is going to cover and what they aren't. Because more than likely, they're going to, if they got coders and billers that are worth the crap and doing their jobs, they're going
Mhm.
to come to that physician after they see, hey, Medicare is not paying this code and they're not going to pay this code. Let's not do this. So they'll get with the physician and see what they can do that is payable that
Mhm.
gets them the same result. So
That's true.
and that's why our job's important, you know, because Medicare's guidelines and the AMA's guidelines change every year. We got to stay updated and let our doctors know what they're doing that's working for them and what they're doing that's not, you know, and also for the patient, not just for them, but also for the patient. Because even if Medicare is not going to pay it, if it's in the best interest of the patient, the doctor is going to do something to find a way around it. You know,
Yeah.
if they're invested in their patients like they should be,
Mhm.
they'll figure out a way to get that patient what they need, the service that they need. Sometimes whether they get reimbursed for it or not, you know,
Mhm.
sometimes they'll just take that hit because they made that oath. That's a good doctor.
Yes, that's
Yeah.
true.
So, and I've seen them do that. I've seen surgeons write off entire surgeries. Did the surgery knowing Medicare wasn't going to cover much of it, and
And
Medicare
it's
ended up
still
not
did it
covering none
anyway.
of it, and they were
On
fine
my
with
death
that, you
reduction
know.
code, and Medicaid will cover it, but most of them don't take Medicare. I think I'm saying that right.
Most it's Medicaid is the one that a lot of doctors don't take.
Yeah.
Most of them do want that Medicare certification. They want that Medicare money. They really
Yeah,
do.
they'd rather deal with Medicare. Well, they really love if you have Medicaid and Medicare together.
Yeah.
They
Well,
enjoy that. But
it's iffy, y'all.
Medicaid still, yeah, still want a lot of doctors don't want to mess with Medicaid because Medicaid only pays sometime a certain percentage. If your procedure is, just say a certain procedure was $1,000,
Hmm.
Medicaid might pay them only $30
Yeah.
or something like that. So a lot
Yeah.
of doctors don't want to
Don't
bother
want to
with it.
mess with it. Don't want to
Mhm.
mess with it unless you have like, okay, good example. When I had my daughter, my normal OBGYN is not a Medicaid doctor. He does not
Mhm.
accept Medicaid normally, unless you were his patient before you got pregnant. If you were
Yep.
his patient before you got pregnant and had to go on Medicaid to help you pay for the cost of your pregnancy, he would
Mhm.
take it for you. And he did it for me. I
Yeah.
was not in a situation where I had insurance and Medicaid was my only option at that time. So thankfully he was able to take it for me. And I was able to see him through my pregnancy. And I had Blue Cross primary as a primary insurance and then Medicaid as a secondary insurance.
Mhm.
So I don't know if y'all know this, whoever has done some billing, but when it comes to Medicaid patients, if that doctor accepts, and this works for Medicare too, if they accept Medicare or Medicaid, they cannot charge that patient over what they agreed, whatever their agreement is with Medicare and Medicaid. Medicaid patients can't be billed. It
Mhm.
is against the law to bill a Medicaid patient anything unless when they walk into your office, they sign something saying, I will pay the remainder. I understand that you do not accept Medicaid and that this will be my responsibility. Unless they sign a statement, they ain't paying nothing and you can't make them.
But then also I've seen it has happened to me once when I had Medicaid and I went to the emergency room
Mm-hmm.
and the person that was doing the paperwork didn't file it as me having Medicaid. They just filed it as personal pay until I
Oh,
received a bill and I called them and told them no, I had Medicaid during that time and those dates. So I had to get paperwork showing that I had Medicaid during those dates.
Right.
But then I did not get the bill until almost 2 to 3 years later. And then when you try to file it, they tell you, no, this is an old bill. I'm sorry.
This is timely filing. We can't mess with that. Yeah.
Yep. And you be stuck with that bill like that.
Well, one of the things I had, I'd gotten admitted to the hospital like 3 weeks before my daughter was born because I had preeclampsia. And I was in there for about 3 days. And with, I don't know how many of y'all know Rapides Regional Hospital in Alexandria, but that's where I had my daughter. And there is a $100 like copay if you're admitted to the hospital with Blue Cross. It was like $100 copay for the visit or whatever for the facility.
Yes.
My doctor's charges didn't go that way. This was for the hospital charges. Well, then people, before I even got the first bill, they had sent that $100 to a collection agency. I don't know why, but they sent that thing quick, like in a hurry. And I got like the rudest people from that collection agency. And he was like, you signed something when you got in there saying that you were responsible for the bill. And I was like, send me what I signed. So he did. He faxed it to me. And I went through it and I read there's this little section. And most people don't know about it. Unless you know about it, unless you do billing, and you know what to look for. Sometimes you get stuck. But there was this lovely little section that said, I understand that I am responsible for this service or whatever. But then it went on to a whole bunch of legal jargon, but it basically said that unless you were insured by a government entity. If you are insured by a government entity, the rules of that entity supersede any contract. So I highlighted that, underlined that, and sent it back to them. And they ended up having to write that off. They had to call the collection agency, get it back, get it off my credit report, and everything else. But it's one of the advantages of knowing the ins and outs of medical billing.
Yeah, that's true.
Yeah. But so chapter 15 exam is tomorrow, y'all. And it's going to be, a lot of the same information that you find throughout your chapter, that you've already gone over in your assignments and all that stuff. So I have no doubt that y'all will do fine. And y'all know, as always, I'm going to offer the retakes. Expect for me to have to manually grade them. Okay. Once you put it in, go ahead and text me and let me know, hey, it's in. And I'll go ahead and get them graded and get the retake open for you if you want it. Okay.
Because when the reason why I'll be having to do a retake, because it'll come up as I'll do it and I have like 3 wrong, say, and it'll give me like a D and I'll be like, wait, how is that?
It's glitchy, y'all. It's glitchy. That's why I go in there.
That's why I text you when I took 14. And I was like, wait, can I do a retake? Because it's saying I got an F. You was like, no, actually you made a B. I was like, okay.
I've got to go in there and look at every single answer. If it marks it wrong, I go in there and I'll look at it because it throws it off. If the punctuation, capitalization, a space, a comma, any little thing throws it off. And some of them, I can't figure out what threw it off. It looked right to me.
Right.
Is marking it wrong. So I go in and I check everybody's regardless of if y'all text me or not, regardless of if y'all want a retake or not. I have to go in and manually check them things. Otherwise, it's gonna mess y'all up, and I don't want that to happen. So if y'all see that it's marking y'all wrong for stuff, don't stress out. I'm gonna go back in and fix it. Okay.
Yeah, I'm one of those that stress because I'll be stressing.
I know you
even if I miss one.
Look, but Kayla, you gotta ask her how many times I text her early in the morning, during the day, just with all type of stuff. And I know I'm a piss. I'm sorry. I gotta get it right.
Y'all never annoy me. Y'all never aggravate me. I love it when y'all text me because that shows me that y'all are here, y'all are interested, y'all are invested, and y'all are gonna do good. Y'all are gonna do good. And that's what I want to see. That's all I want. That's all I want is for everybody to do good and be happy.
Yeah, that's how I am. It's just me. I'm always hard on myself, even if I miss one or two.
Yeah.
I'm like, nah, but yeah.
It's gonna be okay. Ain't nobody perfect. You know, we're all human. Um, and a lot of stuff, y'all, once y'all get into a medical office, y'all see there's so much that the medical office software helps you with and assists you in your job. It's not, and like I also say, once you get into your specific role, you'll be dealing with the same stuff over and over again. Okay. And you'll get accustomed to it and used to it. And those codes and the rules for those codes will become second nature to y'all. Okay. Once y'all are seeing them all the time, y'all be all right.
Yeah, because I noticed when I had one of them wrong, and when I do look it up on the code still comes out to what the answer I had, but then the answer that the computer wanted was a different code, but it wasn't the exact words that the code that the computer gives wasn't the exact words as the question, but the code that I had was the exact
Shoot me
word.
that one.
Okay.
Shoot me a text message with which exam and what number that was, and let me look at it.
Okay. I sure
We'll
will.
make sure.
Since you on here, my question is this: with
Girl, you wasn't the only one.
I said she know we don't know how to draw. Why is she doing that?
Tracy,
That's why I put that picture on there for y'all. I was hoping maybe y'all would just print it out or type over it, you know, whatever. I
traced it, so I'm still confused about what part of the book do I find how I'm supposed to label it, because all I'm seeing is the skeletal system and the muscular system, the front muscular system. So I was confused. That's why I'm still catching up on the lessons that you left open for me. But I'm on this. Like I don't know what to do.
You are right. You are right. All right. Look in your CPT manual. All right. And you're gonna see each of these different sections. You got musculoskeletal. Mm-hmm. And then you've got respiratory.
Wait.
Then, let's see. Where is it? Yeah.
Does it say organ systems? And I just copied and paste, and then I just uploaded inside.
Yeah, that's fine, girl. That's fine.
I'm like, I don't know how to draw.
That was an assignment that came with our curriculum, and I was kind of like, let's see how this turns out. And it was a hot mess. So we won't be doing anything.
CPT manual where? I don't.
Just the different sections. Like if you notice, the different sections are each on a different body system. Okay.
Like the digestive.
Right. Respiratory.
So that's what it means.
Respiratory, cardiovascular.
So it's wait. Okay. Hold on. I'm sorry. I just want to get this while
like
you
like the digestive system, the urinary.
That's what you want us to label, right?
Mm-hmm. And it doesn't have to be exact because the musculoskeletal is throughout your whole body.
Mm-hmm. And the nervous system is through the whole
nervous systems throughout your whole body. So I'm not expecting this in any great detail, y'all. Not at all. I just basically want to know that you know what the body systems are.
Radiology. So you just want the
main body systems.
Main body okay.
Main body systems.
Main body system. Okay, I'll finish that today.
That's all good, girl. It's all good. All right, anybody else got any questions while we're here? No, we good?
Mhm.
All right, I'm gonna go ahead and stop the recording.